Hi, my name is Anita Kamai Ramasar. I'll be the occupational therapist working with you today. How are you?
Fine, thank you.
What brings you to OT today?
I currently work in a doctor's office. I'm experiencing problems in my right hand, especially when I'm using the keyboard and mouse. At night, I tend to wake up several times experiencing problem in my right thumb and middle finger. Occasionally, I have problem doing chores at home, and as well as sometimes I tend to drop things a lot.
Okay, well these signs and symptoms that you're describing to me match some of those of carpal tunnel syndrome. So I'm going to do some assessments and evaluations just to rule it out to see whether it is that or not. Is that okay?
Yes.
Okay, so the first thing that we're going to start off doing is some range of motion testing. Unfortunately, I do not have a goniometer with me today, but I will just be explaining the normal ranges and the movements of the shoulder. So I will have my patient turn this way, see this way. Patient can either be sitting or standing for this, but for today we're just going to have him seated. So the normal degrees of range for shoulder flexion is 0 to 170 degrees. Like I said, patient is seated with the humerus in neutral rotation. The axis is in the center of the humeral head, just distal to the acromion process on the lateral aspect of the humerus. The stationary arm is parallel to the trunk, and the movable arm is parallel to the humerus. So I would first demonstrate the movement that I want to be done, which is this. And then I would position the goniometer accordingly, and then I would have the patient go into full flexion and take the measurements. Then I would proceed with shoulder extension, which normal degrees of range is 0 to 60 degrees. The patient is in a seated position with no obstruction behind them, and the humerus still remains in neutral rotation. The position of the goniometer will be the same as in shoulder flexion, but the access point remains the same for starting and final positions. Movement should be accompanied by a slight upward tilt of the scapula. So then I would have the patient do that as well, and I would take the goniometer measurements. I would first demonstrate it, and then I would be showing the person so they can be looking. And then I would ask you to please move in an extension. And I would jot down that. And I would proceed with testing for abduction, which is normal ranges of 0 to 170 degrees, internal rotation, 0 to 70 degrees, external rotation, 0 to 80 degrees, and elbow extension to flexion, which is 0 to 135 to 150 degrees. And then after I take down all those measurements, I would proceed with wrist flexion. Wrist flexion is so now I would proceed on testing with wrist flexion, which is usually 0 to 80 degrees with the patient seated, with the forearm in midpoint, and the hand and forearm resting on top of the table on the ulnar border. The fingers are flexed or extended. And for goniometer measurements, the wrist is measured with the forearm in midpoint, and the axis is on the lateral aspect of the wrist, just distal to the radial styloid and the anatomical stump box, which is around here and placed here. And then the stationary bar is parallel to the radius, and the movable bar is parallel to the metacarpal of the index finger. And then I would proceed to testing extension, wrist extensions, which is 0 to 70 degrees. Position of client is the same as wrist flexion, except the fingers should be flexed. Then, after I take those measurements with the full range of motions, I would go proceed and take grip and pinch strength. But unfortunately, as I said earlier, I do not have a dynameter or a pinch gauge. But the normal, for females, the normal ranges for the dynameter measurements is 55 to 65 pounds, and for pinch gauge, it is 11 to 16 pounds. After I take those tests, I would proceed with the Tinel signs test, which I'm going to elicit palpitations. So then I'm going to ask the client on their right hand, which is the hand they're experiencing pain. I would have them for the Tinel signs like this, and then I would tap over the median nerve as it passes through the carpal tunnel in the wrist. That would be around here, and I would tap. And then the patient, if it's positive, would say that they
Yes, I feel pain there.
that they feel pain. So then after they said that, I would proceed on with the Bayle's maneuver test, which allows the wrist to fall freely in maximum flexion, and the position is maintained for 16 seconds. And then I would ask the patient to assume this position, where it's fully flexed, for 60 seconds. And after 60 seconds, the patient should have
I feel a tingling sensation in my fingers.
which hand? Both hands, one hand?
My right hand.
Okay, so I would document all of that. Then, with all these findings, I would proceed with sensibility testing with 2-point discrimination tests and the Simmons-Weinstein monofilaments, which ranges from 1.65 to 6.65. The monofilaments would be applied perpendicular to the skin until the filaments bends a little bit and until the patient feels that sensation. If they don't feel it with 1.65, then I would move to a grade higher until they can feel it. Then I would take their hand after all those assessments, and I would check if they have any atrophy by the thenar eminence, and which it looks normal. The results for HA yielded negative edema in her right hand, negative hand atrophy, but positive tenderness of the right hand, radial forearm, just proximal to the wrist. Right range of motion for wrist extension was 0 to 10, 2 to pain. Flexion 0 to 65, but there was full range of motion of all digits. Elbow and shoulder were within normal limits, and the manual muscle testing for wrist extension was 2 negative out of 5. Wrist flexion 4 out of 5. Grip strength was 15 pounds, pinch strength was 8 pounds. Elbow and shoulder were all in normal range from all muscle groups, but there was a decrease in sensation to light touch and pinprick by 40% on the second and third digits of the right hand. Intact hot and cold sensations of the right hand was noted, and positive diagnosis. HA was also independent for all ADLs, but except she reported moderate difficulty with home management, in which she dropped a lot of things, had difficulty cleaning, and had a moderate decrease in work efficiency. With that said, the treatment would be geared to preparatory activities of nerve gliding exercises to avoid adhesions due to carpal tunnel syndrome. So we're going to start off. I'm just going to show you the nerve gliding exercises, and the first one is where the wrist is in neutral, fingers and thumb in flexion, which would be assuming this position. Then the next position is the wrist in neutral, fingers and thumb extended. And then the next position is wrist, fingers extended, thumb in neutral. The fourth position is wrist, fingers, and thumb extended. The fifth position is the same as in the fourth, but except the forearm is supinated with the palm up. And in the last position is the same as number 5, but it's just a gentle stretch of the thumb. And this should be repeated at least 5 times and held for 5 seconds. And exercise should be done at least 3 times a day. In conjunction to the nerve gliding exercises, clients with carpal tunnel syndrome should also do tendon gliding exercises, which are 5 positions. The first one is being straight. The second one is assuming a hook position. The third position is assuming a fist position. The fourth position is a tabletop position. And the fifth position is a straight fist. And you start with fingers and wrists straight every time. Repeat each position at least 5 times and hold at least 5 seconds. Exercises should be done at least 3 times a day. And the client should be given a handout for the home exercises. Also, carpal tunnel syndrome patients, they should be advised to have a lot of rest and not to endure repetitive movements. They should also avoid gripping exercises and external pressure. Functional intrinsic activities and in-hand manipulations are okay. Also, HA exhibited pain, which was 5 out of 10 from the pain scale, which is moderate pain and it interferes with task and concentration. So for pain management, a heat pack for 15 minutes prior to exercise would be advised, and or fluidotherapy for 20 minutes at about 100 to 112 degrees. The client is also going to be advised to just rest and just position the hand properly, and usually a night splint, a wrist resting night splint, can be given with prior approval from the doctor, and the occupational therapist can fabricate that for the client. Thank you very much. One activity that we can do with HA for treatment is that to get a cloth or something to position herself if she doesn't have anything to put under her hand. And she can use something just for support while she is typing at her computer desk to have support and not cause compression on the median nerve. Thank you.